and then just ensure that when the meet comes in, we have a good quorum. So this is the all community Gravity Project meeting for August 6th. Next slide, please. Thank you for joining us. Again, as per usual, due to the large number of attendees, participants are muted upon entry. We ask that everyone stay muted if they can to avoid background noise. There are lots of opportunities to chat and talk, but try to mute yourself as a baseline. The call is recorded, and the recordings are always available on the Gravity Confluence page following. And then we have a really active chat field in our meetings usually. So if you have any questions, we do try to pause and reflect on comments. We do encourage comments in between individuals, and then also we do take the chat and then review it at the end of the call to make sure that we've captured everything that people might have said. When you are sending chats, please do try to send the chats to everybody, just so we can log it as a public reference. Next slide, please. This is some Gravity Project antitrust practices that happen every single time. It's part of our obligations to HL7. Next slide, please. I try again to respect the people come and go. Again, so my name is Sarah DeSilvi. I am the Clinical Informatics Director of the Gravity Project. So welcome to the public call. If you've not already done so, we invite you to officially join the project here. You can follow the link on the Confluence. If you ever want to check whether you've already signed up, you can do so at this link. And then the Confluence is this master set of all this information that one can find. We are building a public-facing website to try to distill some of the more essential elements of the Gravity Project for laymen to review. We're grateful for Highmark and their help with that initiative. Next slide, please. These are our many project founders and kind supports. Welcome to WebEx. I think probably it's not even complete this time. So if you have and your organization have contributed in-kind support or monetary support, please let us know if you don't see yourselves on this list. The full list of project sponsors is always available on the Confluence. Next slide, please. And again, if you're interested in sponsorship, if you know of an organization that might be able to might want to assist in the Gravity Project aims, we're always looking for sponsors, and you can follow the link here or just email gravityproject@emiadvisors.net in order to make a contact regarding sponsorship. Next slide, please. Lastly, we're kind of winding this down, but we are looking and hiring a comprehensive project manager. So if you're here, you already care about addressing social risk and you care about good data. So we're looking for the committed project manager to help organize and integrate both of our project streams. So not only the terminology wing, but also the work of the Fire IG. The application is on the Confluence, or you can email. This is a different email. So this email is hello@emiadvisors.net. Next slide, please. The Gravity Project's on social media. You can find us both on LinkedIn and on Twitter. Next slide, please. And then Evelyn's going to take this over. Evelyn's our program manager. So you're going to take over these next couple slides.
Thanks, Sarah, and good afternoon, everyone. Thank you for joining us today. Just want to give an update on two items. The first one is, as part of our technical work stream, we are developing a fire implementation guide led by our technical director, Bob Dieterle, with support from the American Medical Association. So we do want to acknowledge that the Gravity Track has been set up to test what we've developed so far for the Fire IG. So we invite you to, if you are interested, even if you want to be a participant and observe, you can sign up as different actors. I will acknowledge this will be a very technical testing event. So it's really to go through all the components of the draft fire implementation guide. The link is included here for sign up. We also are partnering with, we have a parallel track called the Care Coordination Track that is working across multiple fire IGs. So Gravity will just be one of other projects participating. But we do, because for this project, we do encourage you to sign up for the Gravity Connect-a-thon if you have a system that can test or is willing to validate what we're working on, because as a reminder to all, until we test what we have, we don't know if it's the best way to support SDOH data interoperability. So, and for those that have asked whether when we will have our planning meetings, we are looking to start up next week or the week after. It's been a busy week. We also have to coordinate alongside HL7 that has asked us to hold off on standing up our track planning, but it is coming up very soon. So please let us know of your interest so we can reach out to you immediately when we're ready to start planning or scheduling the planning meetings. Next slide. Some of you may already be aware, there was lots of press regarding ONC's request for submitting to the United States Core for Data Interoperability, or USCDI. It's open until October 9th. Here's the link to the announcement where you can learn about it, why it's important. As those, you're here because you care about SDOH data. So we invite you as Gravity community participants to submit the data elements and data classes related to the work we've completed. So for those just joining us for the first time, you may not be aware that we already have data elements for food insecurity that we published. We have available LOIN codes. So those are the submissions they're asking for. For those that, of course, ONC as a public agency, federal agency, requests that as many submissions as they can receive. So, for them, it just indicates if they have more than one entity or organization or individual submit, it does count. They review everything. So on that note too, we are working on a formal letter on behalf of the Gravity Project. So we know that this is done for others, and thank you to Lucy. Actually, I do want to acknowledge Lucy Johns, who said that might be a best way to gather feedback from individuals. We are a public collaborative and we want to hear from you. So if you do want to be part of this letter, please send us an email to gravityproject@emiadvisors.net and we'll include you as a name. So, but again, if you can and you're part of a larger entity, please do submit on behalf of your organization. And that's it. And I'll pause. Yeah. Any questions?
Evelyn, this is Al. Could I comment?
Oh, yes, Al, you're on. Yes, please. You're the man. Go ahead.
Boy, you're in trouble now. No, I'm just kidding.
Go ahead.
So to your second bullet on the slide, not only do we invite not just Gravity, but ONC invites anyone to submit any data elements and or data classes through the USCDI on deck. But probably, especially for things that are just getting started, for new data classes that haven't really, the tires have not been kicked on yet, we really strongly encourage people to come in and look at what has been submitted. And the turnaround time on submissions to publication, as long as they're not, as long as they're deemed to be, appropriate for public consumption, the turnaround time for posting those submissions it should be about a week or less. And so we encourage people to come in and review the submissions that are in, and if Gravity submits some, we would encourage them to sort of rally the troops around evaluating the submissions that are there, as opposed to multiple submissions for the same one, rather than comment and support for the ones that have been submitted. And at some point in the future, I'd be happy to go through that process with either Gravity or anyone else for that matter. But I just wanted to highlight that that's another avenue for contribution to USCDI.
Thank you, Al. That's great. And so we'll just take note of that. And when we meet with you, we can that could be an opportunity to present back. So if you start receiving information, before October 9th, and you want this community to also provide input to what's already there, we can schedule on a next public call review of that. Okay, I see one question here. Will you be sharing the letter? Yes, everything we do is transparent. So whatever we come up with, we will publish it and make it available on our Gravity Confluence site. Any other questions before I hand over to Sarah? Okay, back to you, Sarah. Thanks, everyone.
Thank you. Yeah, so maybe we can reserve part of the agenda for the next public call, given that October 9th is a bit away, to kind of wrap around some of the action items from that conversation and bring even the letter back to have everybody see what we've crafted. And then collectively, as Al's saying, maybe comment on a Gravity submission and just offer support from our collective. Thanks, Al, for chiming in. So this is a rough agenda. Again, I'm sorry that it's so many action items, line items that have my name on it. But we're first going to go through some announcements. We already did that. We'll review the project roadmap and upcoming schedule. We do have some adjustments to the master list on the Housing Instability and Homelessness master list based on end-to-end review. So we'll go through those. We do have some updates on some concepts for inadequate housing. We got a few new submissions, so we're looking forward to reviewing those over the coming week. Then community homework and next steps. And then, as always, we are keeping the kind of overview slides about the Gravity terminology development process at the end of the presentation. So if a newcomer should go and try and listen or review the presentation, if you just scroll all the way down to the end in the slides, you will find those slides there. Next slide, please. This is the schedule. I apologize. It kind of I neglected to actually carry it forward, so it's today, and then the stars on today, but we didn't build out the schedule going forward, so that's on me. You can see we are on August 6th, where we are finalizing the end-to-end review comments of housing instability and homelessness. And we are in phase of the concept development and master list development phase of inadequate housing. So for those who might be new, when it came to general housing insecurity, we divided up housing insecurity again into two different phases. So phase 1, housing instability and homelessness. We are just finishing that. Phase 2, inadequate housing. For the final consensus review, we are going to be doing that collectively. So once we wrap up inadequate housing, which is not seeming to take quite as long, we will then go into consensus review for the whole set as one, because so many of the concepts and interventions are similar. So it seems like that's a good use of time. You can see on the right side column, the homework is always there. So the homework for phase 1 is, again, just adding comments if you have them regarding housing instability and homelessness. A part of what we've been doing recently is making sure we loop around a lot of the local experts that you connected with us in your communities. And we've been doing one-on-ones with that. And thank you, Linda, for helping with that. And then submitting inadequate housing concepts. Next slide, please. So this is the tiered timeline. So this helps conceptualize all the work that Gravity is doing at once. There are multiple different streams of work happening at the same time. So we are in a stage of submitting and revising concepts for food insecurity. So we've submitted to SNOMED, submitted to ICD-10-CM, and NCHS, and submitted a first round to Registry, and that was already published in LOINC, as Evelyn mentioned. So we're now in the process of going through some of the more complex multi-domain tools or proprietary tools for food insecurity, and working on a submission for Registry for those to be submitted sometime in the early fall. And then when it comes to housing instability, so we are in, again, the identification of elements for data sets for both phase 1 and phase 2, and working on coming with our comprehensive master sets and then making formal recommendations. After we make formal recommendations in an analysis of those gaps, we will then work to build those codes into their separate terminology systems, just as we did with food insecurity. So we're chugging right along. Transportation is due to start in a month and a half or so, or a month. We are trying to segue it into possibly doing additional domains alongside. So working with our transportation SMEs that we've identified, and planning for that build all along everything. And then the last line you can see is the Fire IG development, which is this ongoing work. We're very grateful for our in-kind support from both the AMA and the AND on that. And that is led by the technical director, Bob Dieterle. Next slide, please. So these are those two streams as they interact. We try to preface this for newcomers. So the terminology build is one wing of the work. The technical build with fire is the other wing of the work, and we intersect in the publication of coded value sets. That's where we meet in the middle. However, in all reality, we're communicating constantly because our work is interdependent as we share vocabularies, terminology, and approaches. So the teams kind of merge constantly. Next slide, please. Any questions on that, what we've talked about so far? All right, so moving on, next slide, please. So these are some of the comments that we've come to with end-to-end review. Again, a preface, so this process is contained in the slides at the end of the presentation, but for those folks who might be new, we spend a fair bit of time brainstorming concepts that need to be included in our data sets. We call this set of concepts that we desire to build the master. We then go through a process of stepping back and reviewing the master and making sure it's complete, it doesn't contain extraneous things, and it says what we want it to say. So that's the process we're in for phase 1 right now. Next slide, please. So some brief comments on things that we've come to. This is kind of like an overview. So we went through and added a program name to some of our interventions. You can see this on the master, and we only did this when it was appropriate. We realized that there was a little bit of a confusion in one of our concepts because health risk assessment was in our intervention suggestions as a capitalized term, and that seemed to reference like solely the Medicare annual wellness visit health risk assessment that's part of that Medicare annual wellness visit process. And so we stepped back and created a generic term that we were in our attempt to basically create like consistency and understanding. So we didn't want to limit ourselves to the HRA capitalized. So 2 new suggested codes are assessment of health risks as a general parent that would correlate to one of the CPT codes we have in our master list. And then a suggestion for a specific code for assessment of social risk. I want to identify that in the naming of health risk and social risk, we're choosing to follow standards of naming that we use in the medical and social care integration work. This is based off the lexicon of one of our founders, Laura Gottlieb and Hugh Alderwick, her colleague. That paper is available as a reference on the Confluence. And so that paper, which defines social risk as a thing assessed at the moment, guided our utilization of these terms and these concepts. And then we removed an extraneous code, evaluation of progress towards goals to achieve housing and security, because it was a duplicate of assessment of progress towards goals to achieve housing security. As we identified in our food insecurity work, according to SNOMED, evaluation and assessment are synonymous. So these 2 were duplicates. Any questions on this so far? All of these changes will be represented on the master. We are trying to, which will be posted on the Confluence. We've established a process going forward of notifying the community through an email when a new master is uploaded, if it's an atypical timing. Usually we upload it on a regular basis after a public call, but in the end-to-end review process, if there's significant changes that we want to make sure individuals are aware of, we'll notify the community of this, so you can be sure to review a fresh master and an up-to-date master as you're doing your work. Next slide, please. So there's a fair bit of updates in the diagnoses realm, and I want to spend some time on this and just get everybody's thoughts. So again, very thankful for our colleagues at the American Medical Association, Monique, for offering insight here. As many of you are aware, so when we're thinking about diagnoses, we're thinking jointly in ICD-10-CM and in SNOMED. So thinking both about claims and about problem lists and history codes and all the places SNOMED can go. So in some sense, with ICD, we're constrained by the existing taxonomy of the Z59 series. And in SNOMED, we have an opportunity to try to build a more logical set. So what you're seeing on this slide is my attempt to conceptualize and visualize the intersection of some of our SNOMED suggestions and our ICD-10-CM suggestions. So any concept that we're proposing to be built into ICD-10-CM is in bold. Any concept that will be solely built into SNOMED is not in bold. So you can see this is the origin, if you remember, of our approach. Housing insecurity as a general parent is the bucket under which these micro or subdomains fit. This is akin to food insecurity having subdomains of quality, safety, stability, etc. So housing insecurity is a general parent code under which we've grouped two different next level children: homelessness and housing instability, which now is slightly changed to have a qualifier of housed. And the reason why this is important is in the literature, you can easily find that homelessness is often defined as a part of housing instability. So homelessness could be defined as housing instability unhoused. So by simply having housing instability without stating housed, it wasn't actually a great semantic representation of this next level. So we chose to say, again, with the help of Monique, homelessness as the next level child, and then housing instability housed as a qualifier on that housing instability. You can see the correlating ICD codes that go along with those next level children. And then there are further refinements we're suggesting based on those two concepts. So homelessness, and you can remember this from some of our previous conversations if you were present. From a risk-based perspective, we identified a need to divide homelessness up into sheltered versus unsheltered homelessness. So you can see we're suggesting ICD-10-CM for both of those concepts. And then you can also see under homelessness sheltered, a SNOMED code for homelessness sheltered doubled up, which is a form of sheltered homelessness. So Lisa, hi. So you said if bold, then ICD-T and, okay. Yes, so excuse me. So Lisa's very helpfully asking me to clarify, everything in bold is also going to be in SNOMED. So it's only when it's not bold that it's only in SNOMED. So bold is ICD-10-CM and SNOMED-CT. Not bold is only SNOMED. And I forgive, I spent a fair bit of time trying to put this all on one slide, so I apologize if it's not clear. But to again clarify, so homelessness has two different children, homelessness sheltered and homelessness unsheltered. And then in SNOMED, we're asking for a further refinement of homelessness sheltered doubled up. You can see, yeah, hi, Lucy. Yeah.
Hi. Do all the experts on the call know what sheltered refers to? I ask that question because where I live is full of homeless shelters, which are, well, you know, the purposes fill a whole page, but they aren't permanent. And therefore, there's a huge goal to get homeless people into permanent housing. Does the concept of shelters include permanent housing with all the social supports that it's presumed homeless people need? Or does sheltered mean, does this mean something temporary?
So this is Joelle and Sarah. Generally, if you're saying sheltered, you mean an actual shelter. It could be a private shelter. It could be a public shelter. It could even be transitional housing, but it's not a permanent house, which would be why they would remain under the title of homelessness. Once you're housing instability housed would be any other kind of housing status.
Great,
but if you're
thank you.
if you're still falling under homelessness, then you're sheltered in some way.
Thanks for that clarification.
Sure.
Thank you, Joellen. And then, we will also be part of our work in submitting both to SNOMED, of course, and to ICD 10CM is making really clear that we define these things well. And we are working with our colleagues at HUD and our subject matter experts, and we'll definitely plumb the community to make sure that this is clear across all settings for implementation's sake. And then Donna is very sweetly acknowledging we need unspecified codes. It is absolutely true. I did not include unspecified at this time because I tried to keep the slides simple, but there are rules in building a taxonomy within ICD 10CM which have to be kept. So thank you for acknowledging that, Donna. So I believe we've covered some of the concepts with sheltered and unsheltered, and then you can see there's a similar building of children out in housing instability housed. So again, we added the qualifier of housed because one can imagine homelessness as being a type of housing instability. So housing instability housed really clarifies better, perhaps not perfectly. This is an individual is experiencing housing instability, but has a roof over their head in a fairly permanent way. And then you can see these concepts that are significant in the literature being built out into SNOMED. So housing instability housed behind on rent or mortgage, housing instability housed history of multiple moves, housing instability housed housing cost strain, and housing instability housed at risk of eviction. We had a suggestion, I think this is important, to further refine a concept for housing instability housed with imminent risk of homelessness. This is significant both from an operational standpoint because one would then qualify for some of the HUD programs for housing once this is established. And it also is significant from a risk-based perspective. Again, whenever we think about building into ICD-10-CM, we're very judicious and we want to make sure we're representing things that carry risk. And so this was a suggestion, and we think it's a very good one. So this would be built again, both in SNOMED, and the suggestion would be into ICD-10-CM. And then at present, we still have a code for housing instability housed history of homelessness. Just hot off the presses from our conversation with our subject matter experts, we're realizing it probably is wise to put recent in front of history. Our last presentation of these concepts had just history of homelessness without being linked to housing instability housed. But once you put it here, you realize that if it's carrying risk, it really is about recent history. If you look at the questions we have in our screening section of the master list, there are two different time frames that are very common when you're evaluating history of homelessness or presence of homelessness. Either 2 months with some of the tools or 12 months with other tools. And so that recent, I think, will help clarify history of homelessness that carry risks and exactly versus one who'd experienced homelessness in a very remote setting, which is no longer carrying risk. So Donna Rugg says, has two questions. Donna, do you want to unmute yourself and offer your two thoughts there?
Sure. Hi, how are you?
I'm doing great, Donna, thanks.
Okay, so you had talked about the 759.811 says imminent risk. I don't know what that means. Is that something, and I don't know the answer, that's why I'm asking, is it something that's documented and known during a patient encounter? Because it would have to specifically say imminent risk in the documentation to assign the code. Yeah,
so just for everyone's benefit, so Donna speaks as a coder.
Oh, sorry.
No, so it's important to know when people, so this is where she comes from a HEMA and as a coder, so thank you. So there are correlating screening questions that correspond to the assessment of this outcome. Yeah. So
Okay.
that would be represented in the approach in some of the questions and answers, and it would not be a judgment call.
Okay, right, because the coder can't do that. It has to specifically say imminent risk someplace in the record in order for them to assign this code.
So that's similar to the risk stratification capable when you ask questions with food insecurity, for example, like severity.
Okay.
Yeah.
Yep. And then you mentioned, Sarah, and correct me if I misunderstood, housing instability, housed history of homelessness. You talked about adding the word recent for recent history.
Well, I'm raising the question, and because literally it was just a half an hour ago that this Mies and I wondered whether that would be important to differentiate history of homelessness that carries risk versus history of homelessness that's so remote it does not. And so recent was a hypothesis that maybe that would be a good concept.
In my opinion, and again, I'm black and white to some degree with from a coding standpoint, is you would have to define recent, and in my opinion, you'd want to define it in the code itself, because the term recent is not very specific. It doesn't give you a time frame. So recent to me could be an hour ago. Typically in ICD-10, the word history just means it's gone now and it happened before. It could be a week ago. It could be a day ago. The condition no longer exists, so therefore it is history.
Thank you, Donna. So Carrie, it looks like Carrie is responding. Do you want, I'm just trying to understand. So Carrie, what did you mean? So yes, it would be for our patients. Carrie, do you want to, hi.
Hi, how are you?
I'm good.
A lot of people who will spend a lot of time in and out of homelessness. So it may have happened years ago. Maybe they got into a stable relationship and then they got out of that relationship. Lots of reasons that we would to document that time frame in a code.
Yeah, so maybe, oh, sorry, yes, who's speaking? Oh, did anybody else want to say anything to that point?
I put a comment in the chat about history of homelessness, Sarah.
Yeah, so I see that. So that's one of the concepts that came up. So history of homelessness ever is one of the things we know from an adverse childhood experiences perspective. So certainly, certainly asking ever is important, right? So maybe we have to wordsmith this a little bit, because Corey Smith, rather than creating individual codes of 2 weeks. So Lucy, yes, because we know that history of homelessness carries risk from a traumatic experiences perspective. And so, and then Corey, do you want to unmute to talk about the capacity to identify time with fire? Because that's you. Can you unmute yourself?
Sorry, there I am. Sorry about that. Thank you, Sarah.
Corey.
Thank you so much. Yeah, just a question. I think we encounter this issue around time often, and the question is whether or not to, include or pre-coordinate how long something happened to go in individual codes, and have to start to create individual codes for every time period we're interested in, versus capturing, the sort of essence of the meaning without the specific time period, in the code, and then capturing, when in an information model, whether that's in the electronic health record or whether that's in FHIR. And I guess I just was interested in the community's, thoughts on where we should, put that aspect of time.
Sarah, this is Donna. Corey, that makes, if I'm understanding you correctly, your suggestion is to not put a time frame in the code itself, but to capture that in the electronic record, like was the person as to when they had the homelessness experience or time frame. That makes more sense to me, because you're right. You'd end up with a lot of codes to try to or you'd have to just say history of homelessness greater than 1 year ago or something like that. And then what if somebody says history of homelessness in the record and they don't tell you a time frame? So then you're preventing yourself from using the code and capturing the data.
Yeah, this is Al from ONC. The idea of effective period or start and stop time could be. I've seen that used in a lot of different standards for other purposes. So that's as opposed to category. Like I think that it's Corey's point about pre-coordination, meaning you have to define it. You have to create a code that says more than a year ago, as opposed to just having homelessness and an element of timing, meaning starting a year and a half ago and ending 6 months ago.
Thank you.
And this is Monique, Sarah. And I'll add here, because Sarah and I had a slight conversation about this last code, for example, even this morning. But, you know, some of these are going to get a little tricky. Like, you know, there's a desire to represent this thing as one thing, that the patient has housing instability, currently has a home, but has been homeless in the past as one ICD code, and that this is really two separate codes. They're currently housed and they have a history of homelessness with some timing on it. So how to deal with all this, you know, is sometimes a little bof tricky, but I think the point of using the information model where possible to capture the time period is ideal.
And I think one of the things I think is interesting, just pulling together, so thank you, Monique, as always, we did just talk this morning, is that because in some sense, the clinical relevance in this instance is in the choosing, right? It's like, so we've talked about time and temporality and things being in diagnoses and in claims before. We've had a really robust conversation about that. I think it was about a month ago, about whether things need to be reevaluated and whether they'd be present and whether they would drop off. But one of the things Roberta's saying here up above is that in some sense, simply like selecting it means it's clinically relevant. And so maybe some of that we can use FHIR to help us establish the timeliness. So is there an action item or a thought to take away based on this, or are we okay pairing, like putting it in the rock tumbler of our minds and working on this over the next couple weeks? Yes, so paired with, so Al, do you want to unmute yourself so you can help me understand what your comments are there?
No, it just goes back, I think it's just sort of a proposal to consider not trying to build automatically pre-coordinate timing into it, because you could have a diagnosis of unhoused, whatever category of unhoused you want, unhoused or unsheltered current, if you decide to pre-coordinate it. But that's going to be, as soon as they get placed, that code's going to be not accurate. Now they have to have a history of unhoused, as opposed to housing unhoused with a timing element that is now expired. And now, you know, there's an end date to that date element that could just be updated.
Thank you, Al. And then Roberta offers some really lovely conversations about time. So we did have conversations early about time and homelessness. It's complex because the moment we define chronicity, we get into operational definitions with HUD programs, and it can get really tricky really fast. So at present, one of the things that we were thinking about doing, understanding the literature, and this is working really closely with our SMEs and our HMIS analysts and, you know, experts in youth homelessness, is leaving it as it is simply now and maybe considering temporality and implementation. But Roberta, I see what I do understand the complexity of episodic homelessness. Hopefully in some instances, well, certainly once a youth who we know suffers from doubling up more often, maybe the risk of that element of couch surfing or sleeping with friends and being homeless according to those standards would be represented by choosing one of the codes above. So it wouldn't have to be represented necessarily in the housing instability housed history of homelessness. But that's, of course, depending on what you're finding with the patient or person or client at that time. Any other thoughts before we move on? So this is, again, do we need, I think we can consider all these different things. I hear really the wisdom of not pre-coordinating time. I hope I've answered some of the questions, that these outcomes really do correlate to some of the screening questions and answers we have in the master, so that it's not going to be a matter of the coder searching. And then we can consider all the other elements, unless there's some other thing to consider before we move on to the next slide. I think we're good. I want to thank everybody for working on this. This is very complex, and I really appreciate how it's evolved over time. I'm very, very grateful for the collective and for our subject matter experts from Children's Health Watch. Thank you. Next slide, please.
Sarah?
Yeah, hi, Lucy.
Sarah, I'm sorry. A lot of this needs to sink in.
Yeah.
There are, I have read, okay, I'm not speaking from direct experience. There are people who choose homelessness. And so history of homelessness from the patient point of view, it may sound perverse to all of us, but may be positive. And I'm wondering, does that matter? Does that enter in here? Would that get into clinical notes? Patient is happy this way. Patient has been this way for 15 years and doesn't want to change. Or I'm just trying to understand, because you said history is relevant to childhood trauma. No question about that. But if an adult doesn't want to be housed and therefore history of homelessness is going to be a yes, I'm wondering how that would be dealt with.
Lucia, this makes me think of, so Carrie has some thoughts there. So number one, I think there would be some conversation ideally about whether that would even be an assessed concern for the patient if they're happy. So whether it would even make, like, I mean, we'll have to, I mean, I'm not going to be pie in the sky here, but that's my first thought, is that if it's not an assessed problem, maybe it doesn't make it to this stage. But then I also want to honor what you and I were emailing about this week, which is we really are working hard, and this is not represented here because we don't have anything final. We don't have anything final to relay. Is we're working really hard to try to figure out how to represent the desire to stay just as you are. That was raised as a goal in the goal conversations about a month ago. And one of the things we're considering is whether we can take a harm reduction approach to it, because really, and so there's a lot of work to be done there to really try to represent that well, like no change as the goal. So, and so we're taking that back to the hopper. I'm going to go and talk with folks from the Healthcare for the Homeless world and see if we can come up with something.
Okay, thank you.
Yes, and so Paul Nelson's commenting that, so Carrie says, even when patients choose homelessness, sometimes they still have difficulties with finding places to camp. Exactly, so that would be someone who is contentedly homeless but needs assistance. And we do have some interventions and goals with that in mind built out so far. Paul's talking about chronic homelessness is substantially different from other designations, and Gabe says yes. And Gabe, as part of the HMIS HIT subgroup, knows that we wrestled with operational definitions of chronic homelessness from a HUD perspective with a lot of thought. And then, okay, I'm thinking, so at this point, so Teresa asked, will there be subcategories for imminent risk, such as foreclosure or eviction in process, abuse situations? We don't currently have those represented, but if you can, if you feel like they are missing, then please submit them. I mean, eviction in process is contained, foreclosure or eviction in process is contained kind of in what we've suggested. But if you feel like it's not sufficient, please submit a comment and say that needs to be there, and then we'll bring it back to the group. Yeah, and then Monique echoes what I was saying again about problems being co-identified. Okay, I think we're good. Gabe's talking about history of homelessness was brought up in the context as a description of why someone might be housing unstable. Yes, Gabe speaking to the lit there. Thank you, Gabe. Okay, so just, and again, a review for folks. I mean, it was a very lively conversation. I'm always so grateful for you guys. I wanted to just again frame the process of end-to-end comments and why we do it. And I've been doing this level setting more and more, trying to make sure that folks who might be new don't get completely overwhelmed. So end-to-end review again is after we spent months adding and winnowing the collective data set together. And again, that's available on the Confluence. You can also email us and we'll send it to you. End-to-end review is a time to step back and consider the whole set and ask questions. And the questions are there missing concepts? And Teresa Gerard just questioned whether there might be. Are there incorrect concepts that need to be changed? You can see some of the edits that we've done in the diagnoses weren't necessarily incorrect, but maybe not as helpful from a semantic perspective as they could be. And then are there concepts that are unnecessary and should be removed? So far with housing, we've removed a duplicate, but other than that, we haven't had anyone say that the concepts there that we have in the master set so far are unnecessary. So these are the processes and the questions we ask ourselves. Again, that's all represented on the Confluence, but it's nice to level set here. We've had a really robust conversation. I'm going to try to step into some of the inadequate housing concepts and do a segue now. So again, this is the process for how to submit end-to-end review comments. It says the deadline is 8/6, but you know, if we're rolling, we're gentle, we're not going anywhere. We've already agreed that we're doing consensus voting collectively. So if you have a piping comment and you want to get it in, please try to do so swiftly, but we're here to receive it. Next slide, please. Any questions before we segue to inadequate housing? All right, next slide, please. So some updates on inadequate housing. Next slide. This is our housing data element submission summary. We just received a comment that was framed as an end-to-end review comment, but has data suggestions. So this is not contained on this slide, but we did receive some new suggestions for inadequate housing that we'll be adjudicating shortly. Next slide, please. Again, this is just some level setting regarding definitions and common tools. Next slide, please. So this is a working slide in progress. So if inadequate housing is the current ICD-10 code, ZFD 9.1. Assessments of housing adequacy is the way HUD usually talks through the American Housing Survey. So when we start to try to think about how adequacy plays out in clinical settings, it becomes a little bit more vague than we like. And if folks can remember, we've had conversations about adequacy being relative. Like, again, the best example is the example of pests in Hawaii, that conversation we had in the past. And so one of the things that was suggested again by Monique, and we're grateful, is trying to conceptualize what we mean by housing concerns of quality in reference to local standards. So we have a couple different suggestions of how we might do this, and we'll be working on it again as we go forward with the inadequate housing build. But the suggestion would be possibly stating that we're talking about substandard housing, and then giving subdivisions for all the different types and different concerns. So another suggestion from Monique at the AMA was housing does not meet jurisdiction habitability standards. And then that concept would be carried through. But you can see what we're trying to do here is really create a kind of a regional reference and a local reference for assessment of housing elements that might be affecting health. This bold and not boldness does not do the correlate to to ICD-10-CM and SNOMED. We haven't resolved what comments will be, what elements will be on SNOMED and what ones will stay in ICD-10-CM. But this is a work in progress, and I'm wondering the community's thoughts on how this might address some of the complexities we discussed regarding inadequate housing in the past. Does this seem like a good approach to clarify how housing quality might be affecting health? Crickets. Anyone have any thoughts about this, or thoughts to put in the chat? We can let you all mull it. You will see this reflected on the master, because we are trying to answer the question of how housing quality affects individuals clinically better. So the only question, so Carrie has, the only concern I have is how we might determine overcrowding. Yeah, so this, we would have to use the definitions. We have the questions in the American Housing Survey that look to overcrowding. Overcrowding is a tricky one because in some instances it's a concern, in some instances it's a cultural norm. So it's one of those ones we have to, like, certainly when it comes to the current use case of COVID, it's important to consider overcrowding as a complexity with discharge planning or with isolation. But again, culturally, some individuals are more than accustomed to living in housing and sharing bedrooms and sharing spaces far more than others. So we do, it is complicated to look at the effect of overcrowding in the lit.
And Sarah, this is Monique. The other issue with this one that we haven't gotten to yet is that there's a very fine line between this code, substandard housing due to overcrowding, and the housing instability housed but doubled up, or this is all a fine line that we'll have to sort out.
Those are, the good thing about those two is they can seem confusing, but they are defined
differently.
They're defined differently. And then, so Lisa has a question about whether using these codes can prompt mandatory reporting when children are in the home. I'm going to let you speak your question, and then maybe we can come up with a collective answer. So, Lisa, do you want to unmute, or do you want me to just see what? I assume this is a different. Is this Lisa Nelson, or is this a different Lisa? This is not Lisa Nelson. So, if you're not wishing to unmute because it can be a little overwhelming, or maybe you can't find the button. The initial identification of housing concerns does not usually require mandatory reporting of any kind. So we do, and again, I'm speaking as a family clinician and with some degree of knowledge. We're very cautious, actually, when we're working with social risks to make sure that we're very clear about involvement in child and protective services, because it's definitely a fear. But the initial assessment, again, and the willingness to receive intervention would not usually be indication for any concerns. A perpetuation of concerns in the absence of willingness to receive resources is another thing. But if we judge people as fit based on their ability to provide a shelter that's in poverty, it would be really ethically complex. No, and that's again, I'm not a lawyer, I'm not a specialist, but again, from an ethical standpoint, the initial assessment would not be indication usually for reporting.
Another comment on the phone, if I might.
Yeah, please.
Yeah, this is Dan Anderson from Rely. I mentioned something similar on another call, and I do realize it might not even be addressable, but I just wanted to make sure we kind of socialize this again. I'm looking at this list, that identify substandard housing. I know it's to meet this jurisdictional habitability standards, but what pops to my mind as a gerontologist and aging and place-minded person is like a person, an older adult, say, with some mobility issues, might live in a house that meets all these standards, but still it's like you would consider, a reasonable reviewer would consider it substandard housing for them, because I mean they can't use the kitchen because like the person environment fit is so out of whack that it's almost, the house is unusable, but people are holding on to not be institutionalized. So I mean, I don't know if that meets the need, the intent of this code, but I do want to raise it because it's an important point, and more it might not be addressable, but I just wanted to put it out there.
Again, so pardon me, so what was your name again, sir?
Dan Anderson.
Dan Anderson. So thank you so much for making that comment. We have actually talked a lot about that so far because it's impossible to consider safety in homes without considering the intersection of the house itself and the person. As currently defined, that is not necessarily in scope in the definition of this approach, but it needs to be defined. And again, so we are a multi-domain initiative, right? So I think we need to figure out, and maybe you'll be a great ally in this, how to frame that. It might not be under Z59.1. right? It might not be in this route, but it needs to be represented because it's critical. But I do want to reassure you, we've spent a fair bit of time wrestling with that. And we had lots of, Linda can testify, we did have multiple submissions that were talking about individuals living in houses that were unsafe to them because of their own needs or their own abilities. So that's definitely a sticky wicket that we have to figure out.
Yeah. Yeah, well, I'd be happy to work with anybody on creating some additional code or something else for that.
Yeah, that is what we have a parking lot.
All right.
that is in the parking lot. And then, so we're getting some echoing from Carrie. And then Carrie saying she's be interested in working on that. Yay, Carrie, thank you. And then Mark Savage is saying, is there a difference between housing a substandard or a person's not capable? Okay, yeah, so this is the intersection again of the individual and their home environment. So I think that is where you fall on either side of the fault line. And then Jane is, so the central issue is safety rather than lodging. I guess I'm going to say it's quality. So when we think about concepts to group these matters in, and we did the same thing with food insecurity. The easiest way for me to wrap my brain around it is it's a quality statement, and perhaps a safety statement, but in some instances it's just a quality, like a quality statement, and not necessarily able to be qualified as safety. And we did have a
Sarah,
hi, Lucy, yeah.
Sarah, sorry. Could there be a huge bucket called substandard housing due to patient, I don't know what to say, issues, inconvenience, perceptions? Could there be a huge bucket that would fit in a numerical code, but would have to be elaborated in documentation by a human being? Or do we have to keep parsing this? It seems to me the more we look at it, the more we're going to come up with reasons that a clinician might consider housing substandard, and indeed the patient might also. But there's probably 1,000 reasons that a patient might think that something is substandard or a poor quality. Going back to that, quality is so unconstitutionally vague. I just wonder whether there could be one bucket here: substandard housing due to other reasons. See clinician notes. or something?
There will be that, absolutely. So we have, we always do try to make a way to represent the need in the simplest possible fashion. Because depending on the capacity of your team or resources or time, right, we have to let a clinician or professional or a community member move through the move through time with the patient. We have been asked to build these just for following up on, because the issue with this is so many of the issues in quality have very specific different interventions. So if you're trying to follow up on concepts, the subdivisions of this can be helpful, but certainly if you're not trying to follow up on them, I entirely agree. We don't want to create a cacophony of unused concepts, which is why we create these general parents for people to use if desired. And then I like the idea of trying to figure out a general, we'll conceptualize together a way to represent the intersection of the person and their environment from the person's perspective. Lisa, all aspects of information need to have a code. I love that. Any other comments here? Again, so I'm going to just represent where we are here because it can be a little confusing. So we're at the end of a process with housing instability and homelessness, and that was phase 1. And that's represented by the master, right? So what we're doing in that area is the end-to-end review, offering final comments, tweaking this or that. We're in the middle of a process with inadequate housing, which is building, brainstorming, collectively coming to ideas, reviewing what's out there and adding things that are missing. So I just want to make sure for anyone who's new that you understand there's 2 different kinds of activity happening at once. The end-to-end review and then the brainstorming. So inadequate housing, brainstorming. Lisa says, does not need to have a code. Okay, thanks. I was wondering, Lisa. All right, so this is where we are with some of our diagnoses, concepts with inadequate housing. Next slide, please. And again, this is just the framework to think of. If you go to the master, you can see we organize data concept into screening tools, assessments and diagnoses, goals and interventions. And then we do always try to ensure that if individuals are giving interventions, they give us definitions for any kind of program. And then we do, again, conceptually, loosely divide things up into programs, providers or practitioners, and any kind of activity. Oh, thank you, Denise. Yeah, safe at home programs might lend some insight, and definitely some of the home supporting seniors at home nursing programs and areas and agencies on aging will definitely be helpful with that as well. Next slide, please. Again, I'm going to move through this. This is just some of the data brainstorming questions we ask ourselves as we're in this brainstorming process, which is really just putting on different hats and trying to make sure we represent data needs from patient perspectives, clinical perspectives, community perspectives, federal perspectives, state perspectives, and also hospitals. Next slide, please. Any questions? I think we're on to homework next. It's been a very robust conversation today. Community homework and next steps. Next slide. So general homework. Catch up is needed on materials and recordings on the Gravity Materials Complements page. You can see the link there. So again, end-to-end review for phase 1 and housing instability and homelessness, wrapping that up. You can find the domain page at the link, and the master, again, is updated after this call. And if it's updated more swiftly, we'll send an email. And after this call sometimes means it'll take like Monday for us to get to it, just to be honest. And then inadequate housing, we're in that brainstorming phase. So submit new concepts. If you have a person you need us to talk to who's an inadequate housing or housing quality expert, connect us to them. We want to make sure that we represent all of the information and knowledge that's on the ground. There's lots of conversations about, Lisa and Corey are talking about fire in the chat. Next slide, please. Again, join the Gravity Project as a committed member or other interested party, and then sign up to be part of the Connect-a-thon, as Evelyn was mentioning. So we're looking forward to getting going with some of those work group tracks in the next couple of weeks. Next slide, please. There we go. Any final questions? Again, I'm sorry for keeping you a little over today. It's 5:05. It was a very robust conversation. Anything else anyone wants to wrap us up with? So Dan Anderson and I have a mission with Carrie Nichols to try to think about the unique issues of elders and any individual with different abilities intersecting with their home environment. You all have homework, and we're always here for you. And thank you so much for joining us on this Thursday. If you have any pressing comments or ideas, just feel free to send us an email. Thank you so much.
Thanks,
Thanks, Sarah, and everybody.